Yeah, yeah. Yeah, those visibility days. I'll be like virtual Monday, Friday, Saturday, but yeah. Mhm. All right. Should we go into our last hour together? We're off into the world. We are going to finish off with some reproductive pathology. We'll start with women's repro, and then we'll move into reviewing a few of the men's repro conditions that we kind of sped through. And then I may ramble for a little bit on a couple things I didn't include in the presentation. So on like some enzyme deficiencies and a little bit more on Kleinfelters and Turner syndrome. So for our repro path, I just want to introduce you to main conditions at this point. Goal is not going to be to learn everything about everything, right? This is not a diagnostic test. So our goals are name recognition. What does the disease involve? And is there any pathognomonic lesions or specific like epidemiologic characteristics you should know? So to start us off, we're going to focus externally. So on the actual external tissue for females, looking at vulvar pathology, we have lichen sclerosis and lichen simplex chronicus. Lichen sclerosis is chronic and it's progressive and it's inflammatory. It looks, if you saw it externally, it's porcelain white plaques. They can bleed, they can break off, they can be ulcerated. It can extend off the vulva into the surrounding tissues, including even into the anus. Typically, we see this prior to puberty and then after menopause. So we see it kind of pre-puberty and post-menopausal, so typically not as common in our reproductive years for lichen sclerosis. Typically it's benign, but it can increase risk for squamous cell carcinoma, SCC. Yes. This is the repro PowerPoint, reproductive PowerPoint. Reproduction. Oh, this slide I just added, so you don't have this slide. Sorry. My bad. Just added it, like right now. I just wanted to have a slide on it. I will repost it right after, I promise. You're not... I just did not mean to gaslight you. I'm sorry. All right, especially this close to an exam. There's no time for that. Okay. She's like, no time. All right. Yes, this slide did not exist before. I literally made it when you all stepped out for break. Okay. I think the next slide. Yes, you should have this next slide. Great. Okay. It's the only slide I added, I promise. Lichen simplex chronicus then is hyperplasia of the vulva. And it's specifically of the vulva squamous epithelium. It is benign. There's no risk for SCC. So that's the big difference. Lichen sclerosis, it's chronic, it's progressive, it's inflammatory, and you have a slight increased risk for squamous cell carcinoma. Lichen simplex chronicus is hyperplasia of the tissue, but it's not chronic, it's not progressive, tends to be more acute, and it's benign with no risk for SCC. The lesion for lichen simplex chronicus is more leathery and thick vulvar skin, which makes sense if you think about a hyperplastic state or hyperplasia itself. The markings, though, you don't have the white plaque lesions like you see in lichen sclerosis. Lichen simplex chronicus, it's more leathery, thickened skin. You may see some excoriations from patients scratching because both are very itchy conditions. Okay. Now we're moving from the vulva to cervical pathology, so kind of moving up. And we're going to start directly with dysplasia and carcinoma in situ. So this is disordered epithelial cell growth, and it's categorized as CIN 1, 2, or 3, depending on the level of severity. We want to associate it with HPV type 16 and 18. That will be asked. But also keep in mind that vulvar carcinoma is also associated with the same two types of HPV. And I've seen them ask that question about VIN 1, 2, and 3 and asking about HPV subtypes involved. It's the same two, 16 and 18 for both, increased risk for carcinoma. Okay. When it comes to our carcinoma and dysplasia for the cervical region, for the cervix, Coliocytes are the pathognomonic lesion of HPV infection that you can see in CIN 1, 2, and 3, although you could see them with just HPV infection on its own, but they tend to ask it in correlation with CIN 1, 2, and 3. Risk factors could be multiple sexual partners, HPV infection, that's really why the multiple sexual partners is there, smoking, early onset of sexual activity, that's coitus, DES exposure, or immunocompromised state. These are really your big risk factors. They often aren't going to ask you to differentiate between CIN 1, 2, and 3. This is not treatment. This is really diagnostic. They are going to ask you what HPV types are associated. They are going to want you to know it's a association with, it's a carcinoma, it's epithelial cell growth, right? Carcinoma means epithelial cell cancer. And they may ask about choliocytes. Those would be your most commonly asked questions about this condition state. Okay. You can have invasive carcinoma. This is when you are dealing with squamous cell carcinoma. That's the tissue type that's involved. Invasive carcinoma is just meaning it's going to invade into other tissues. You are going to initially typically see a cervical dysplasia first before you get to invasive carcinoma, where it's invading through the basement membrane, through squamous cell tissue into other surrounding tissues. All right. Primary ovarian insufficiency. So we're continuing to move our way upward now. We will get back down to the uterus. I kind of skipped and jumped to the ovaries. But primary ovarian insufficiency, I want you to recognize this as also called premature ovarian failure. We do not call it that anymore clinically, but NPLEX will. So POI and POF are the same condition, okay? This can be idiopathic. There can be a chromosomal or genetic abnormality or predisposition, or an autoimmune component as well. All three could be potential etiologies. You'll typically see low estrogen and high FSH and LH. When I see POI asked about, they're asking it about in relationship to your anterior pituitary hormones secreted and what you would see being high or low. So know that POI, you'll see a low amount of estrogen, but a high amount of FSH and LH. That's also what you would see in menopause, right? Low estrogen, progesterone, high FSH, high LH. Okay. Great. Typically onset, you'll see menopause onset prior to the age of 40. So this would be early onset menopause, you could say as well, but they'll call it POF or POI. I hope they call it POI. The last time they called it POF. Okay. So then we get to other causes or other issues with ovulation or fertility. So functional hypothalamic amenorrhea. This is your exercise-induced amenorrhea, or it's where you get to your athletic triad, your female athlete triad, where you have low calorie availability or excessive exercise, low bone mineral density, and menstrual dysfunction, often in the form of amenorrhea or at least irregular cycles. This is due to functional disruption of your GnRH secretions. It's coming all the way up from the top. So you're actually leading to a dysfunction in that normal pulsatile GnRH secretion that's affecting then your pituitary and everything from there below. You'll also see decreased leptin because you're in a fasting state and a high exercise state, and you'll see increased cortisol from that high exercise state. So increased stress on the body. This is where we could also get to the thought process of stress, decreasing menstruation or delaying menstruation, right? It's same idea with that cortisol potentially affecting that pulsatile secretion of GnRH. PCOS, the things I want you to think about with PCOS, and again, this is not getting into diagnostics and treatment at all. So it's like crushing my soul a little bit as someone who does women's health. But I'm just trying to stick to pathognomonic things, pathophys, and any risk factors that you could be tested on. So polycystic ovarian syndrome associated with hyperinsulinemia. So could be associated with insulin resistance. Not always the case though. But that hyperinsulinemia or insulin resistance, the hypothesis, we haven't confirmed this mechanism, is it alters hypothalamic hormonal feedback responses. You're going to see an increased LH to FSH ratio. That's what this is, increased LH to FSH ratio, as well as increased androgens like testosterone. You're going to then, therefore, that will affect your follicles. You'll see a decreased rate of follicular maturation. So you'll have more unruptured follicles that will present themselves as cysts in the ovary, hence the polycystic component. There are multiple follicles that haven't ruptured and gone through that final stage process to then be reabsorbed. because there's multiple follicles that haven't progressed that maturation process, you can have inability to ovulate or inconsistent ovulation. That's where you get the infertility component of PCOS. There are risk factors associated, any type of state that could increase your risk for hyperinsulinemia or for insulin resistance, so diabetes, more fat cells. Fat cells are going to affect our hormone secretion and insulin status, acanthosis migricans. And all of these pieces are also to state that PCOS does increase your risk of endometrial cancer because you will have some unopposed estrogen because you have continued anovulatory cycles. So that is where we get concerned about PCOS, diabetes, endometrial dysplasia or hyperplasia or cancer in this condition. That's why in some patients that have PCOS, we do breakthrough bleeds because we don't want that endometrial lining to get built up. So we induce a bleed to kind of keep that lining thin for these patients if they're not consistently ovulating. Okay. Other ovarian stuff. Those were some ovarian things. Now we're getting into the cysts and the tumors of it all. So ovarian cysts, we have 3 different types of cysts I'd want you to know: follicular, corpus luteal, and fecal lutein. This depends on where they're located. Follicular is what we hear about the most. Almost all of the ovarian cysts are typically asymptomatic until they're not, right? Asymptomatic until they're big enough that they cause pain or rupture or bleed. So while books will say they're asymptomatic, most of the time when you're seeing them clinically, they're causing pain, bleeding, rupture, they can torse. There's lots of symptoms associated. But that's where you get the asymptomatic piece, because as they're growing, you might not notice when they start. The follicular is going to be your functional or your physiologic cyst. It's the most common ovarian mass of young females. It typically is estrogen producing. The cause is the failure of the mature follicle to actually rupture and for ovulation to take place. So instead of the mature follicle rupturing and ovulation happening, that mature follicle continues to grow and becomes your cyst. Typically, they'll resolve spontaneously. Rupturing and torsion would be your 2 complications. A corpus luteal cyst is also a functional cyst. It's failure of your corpus luteum to involate after ovulation. This one will produce extra progesterone. So whereas your follicular produces estrogen, your corpus luteal will produce progesterone. Typically, this will also resolve spontaneously. And then your thecal lutein cyst, this could also, this is typically caused by HCG overstimulation. You'll often see these bilaterally or multiple of these occurring at once. So it won't just be on one side or the other because HCG is going to affect the tissue systemically. You can see this in more gestational trophoblastic diseases. So things that can actually affect gestation, things that could affect during pregnancy. This would be your least common ovarian cyst to see. In fact, I've never seen them test this one, but they could. Some ovarian tumors. In general, increased risk is going to be with age, number of ovulations, endometriosis, and genetics. Decreased risk is pregnancy, breastfeeding, OCP use, and tubal ligation, ironically. A lot of the decreased risk is if you had a previous pregnancy, you're not having unopposed hormones. If you have OCPs, you're taking them and potentially correcting for any hormonal insufficiency or deficiency or dysfunction. OCPs will increase risk for other cancers and other tumors, right? But not necessarily ovarian. Breastfeeding for the same reason that pregnancy decreases risk. Tubal ligation, because you've stopped ovulation, so less likely chance that things will be as wonky if we're not ovulating. I don't know if I fully believe that one, but I'll take it. That's what it says. I'll go with it. It's what the CDC, it's what the up-to-date says. We'll stick with it. Okay, epithelial cell ovarian tumors. So these are all tumors that are from epithelial cells. So I tried to just pull like some important terms for you to associate. Again, name recognition is key here. Your serous cystoadenoma is benign and the most common ovarian neoplasm. So a good one to know. The mucinous cystoadenoma is multiloculated and associated with mucus accumulation. Brenner's ovarian tumor is benign and has a coffee bean nuclei appearance. Serous carcinoma is the most common malignant neoplasm. You pathognomonic or your pathognomic thing would be the pneumoma bodies. And then mucinous carcinoma is malignant and rare and typically metastasized from other GI tumors. So which one would I know on this thing for epithelial cell ovarian tumors? Serous cystadenoma, because it's the most common neoplasm and it's benign. And then serous carcinoma, because it's the most common malignant neoplasm. Both of them have serous in their name. Both of them are epithelial cell ovarian tumors. One's a cystadenoma and one's a carcinoma. So one's dealing with essentially the fallopian tube-like epithelium, that's the cystadenoma. The other one is dealing with your actual epithelial lining of your ovary, carcinoma. Your germ cell ovarian tumors, there's 4 of these to know. I'll just point out the highlights. Mature cystic teratoma. This is a dermoid cyst. It's benign and it's the most common tumor type in young females. Not just ovarian tumor, common tumor type in young females. Immature teratoma is malignant, aggressive, and also diagnosed young. So a mature teratoma, these are not like, the immature doesn't grow into a mature teratoma. These are 2 different conditions. So your mature cystic teratoma is benign and most common tumor type. Immature teratoma is malignant and aggressive, both diagnosed in young women. Dysgerminoma, malignant and the most common in adolescents, so teenage years. And then the yolk sac tumor, you'll see this in children and young adults, malignant, aggressive, and Schiller-Duval bodies are your pathognomic component. Of these, I would know immature teratoma because it's malignant, aggressive, and typically but diagnosed prior to age 20. And then your last ovarian tumor type. Who knew there's so many types of ovarian tumors, right? So that's why name recognition and only remembering a couple of them will be key. So I would only focus on a few, the few I highlight on each slide, not all of them on each slide. So you have your sex cord stromal ovarian tumors. You have a fibroma. This is essentially a growth of fibroblasts. These are benign. A thecoma, this is also benign. It's estrogen producing. You'll see this more commonly in postmenopausal females associated with abnormal uterine bleeding. A Sertoli-Leydig tumor, this is benign and androgen producing. And a granulosa cell tumor, this is the most common of the group. So this is the one I would know. And it can produce estrogen and progesterone. And you have a Call-Exner body as a pathognomic lesion. So if we go back and look at our ovarian tumors as a whole, the ones I would pay attention to and remember of your epithelial cell ovarian tumors, know your serous cystadenoma and your serous carcinoma. This one being the benign, this one being the malignant. Of your germ cell ovarian tumors, I would know your immature teratoma because this is malignant and aggressive. Of your sex cord stromal ovarian tumors, I would just know the granulosa cell tumor. This is the most common of the group, produces estrogen and progesterone. So just 4 tumors I would commit to memory if you can. Okay. All right. Moving out of tumors of the ovaries into the uterus. Adenomyosis. This is an extension of endometrial tissue, of glandular tissue that moves into the uterine myometrium. It's essentially an overgrowth or hyperplasia of the basal layer, that bottom layer of the endometrium. It's associated with lots of pain, dysmenorrhea, abnormal uterine bleeding, a soft kind of gushy uterus. Oftentimes you're having to do surgery to correct or hysterectomy to correct. Symptoms will look like endometriosis for adenomyosis. Asherman syndrome is adhesion. So think Asherman's A, adhesions A. So adhesions or fibrosis of the endometrium. This can be associated with decreased fertility and increased loss of pregnancy because of that fibrotic tissue. It will affect the ability for the endometrium to develop that nice squishy lining for an implanted embryo, and therefore will affect potentially placental development. Okay. Endometrial hyperplasia sets us up for potentially endometrial cancer. It can increase our risk for endometrial carcinoma. So that's my main thing I'd want you to know about endometrial hyperplasia. It's essentially abnormal endometrial gland proliferation growth. Excess estrogen states are going to stimulate endometrial hyperplasia. So anything that can cause an excess estrogen state can increase your risk here. So we see this commonly with our PCOS. That's how PCOS has the increased risk for endometrial cancer, is because of its risk of endometrial hyperplasia, a granulosa cell tumor, hormone replacement therapy, or anovulatory cycles. Anytime you're going to have that follicle that sticks around that can continue to produce estrogen, that's a hyperestrogenic state. Endometriosis, on the other hand, you'll see endometrium-like glands and stroma outside of your endometrial cavity. You most commonly see this occur in the ovary, pelvis, and peritoneum, but you can see this occur, anywhere in that pelvic bowl space. Your symptoms are going to be wide and broad, but think chronic pain, heavy cycles, and irregular cycles, irregular menses, but really significant pain, not just to the pelvic region, not just with PMS, but chronic pain, heaviness, fullness of that region. Naturopathically, we can do so much with that, but that's another lecture for another day. Come talk to me or Dr. Winster. Endometritis is inflammation of the endometrium. Oftentimes, this one's associated with retained products of conception. So after a spontaneous or therapeutic miscarriage, that's when you can see potentially that occur. And then we get to endometrial carcinoma. This is going to be the most common gynecologic malignancy. So when we think about our malignancies, I made a little table, so silly, but I made a table of which ones are most common. Endometrial is the most common, followed by ovarian, followed by cervical. So if you're thinking about which area is most likely in this region, the pelvic region, to have some type of malignancy, endometrial first, then ovarian, then cervical. When we talk about prognosis, it's completely different. Cervical has the best prognosis because it's typically caught the earliest, right? So cervical has the best prognosis. Then endometrial cancer has the second best prognosis because it tends to be caught the next earliest. And then ovarian cancer has the worst prognosis because it's tend to be caught late. That's the reason why that prognosis is listed in that order. It's based off of stage of diagnosis and age of diagnosis, typically. Yes. Talking about US in particular, if we talk about worldwide, cervical cancer would bump to #1 for epidemiology. Yep, for most common, because of lack of adequate PAP screening and HPV screening. Yes. And vaccine status. Absolutely. So the question was, this is just talking about the United States when it comes to cancer onset. And I said, yes, if we're talking worldwide or globally, for epidemiology, not survival, but epidemiology, cervical cancer would move to #1 most common diagnosed, then endometrial, then ovarian. But in the US, because of vaccination and cervical cancer screening and HPV screening, it's the opposite. It's the first one I said, endometrial, ovarian, cervical. Okay. Other things about endometrial carcinoma. There's kind of two categories or two types, endometrioid and serous. Endometrioid is where we see unopposed estrogen exposure. You could see this with early menarche, obesity, our adipose cells increase estrogen, late menopause, so having cycles for longer in life, or null parity. We know when we go into a pregnant state, we're going to promote or produce progesterone. So estrogen is not going to be unopposed, right? And so that's why pregnant null parity often increases risk for things that have unopposed estrogen exposure. You'll see loss of P10 sometimes in this, or essentially mismatch repair proteins. You're not able to repair this cancerous, this oncogenic process as effectively. In our serous form, you'll see endometrial atrophy, and this is typically occurring in postmenopausal females. This is more aggressive, and you can see psammoma bodies, which is that pathognomonic lesion that we saw previously in our ovarian cancer. Leiomyoma or fibroids, these are non-cancerous neoplasms. They're the most common tumor in females. The peak incidence is 20 to 40 years old. Typically, you'll see multiple tumors. They're just often discrete. When they present, they're smooth muscle in nature. They're benign, very rare to have any transformation to malignancy. They are estrogen sensitive, so they increase in size with pregnancy and they decrease with menopause. So typically women who have fibroids or leiomyomas are going to see those fibroids shrink or decrease in size once they go through menopause. Because of their location and because of the increase with estrogen, they can have issues with fertility because they very much can block or obstruct the areas that a potential embryo would want to implant. Leiomyosarcoma, this is malignant proliferation of smooth muscle rising from the myometrium, typically seen in postmenopausal females. Often it's just one single area and it can be associated with necrosis. Okay. We're moving out of the uterus, moving up to breast tissue. We're going to talk about breast cancer and other breast stuff. So fibrocystic changes, most common in premenopausal females, so females of childbearing years. We can see two types of ways that these fibrocystic changes can occur: sclerosing adenosis and epithelial hyperplasia. Sclerosing adenosis is associated with more calcification. This one has more of an increased risk for cancer. Anytime you hear calcifications, cancer should be in your brain, right? And epithelial hyperplasia, this is more actual overgrowth of cells. This could increase risk of specifically carcinoma if the cells become atypical, right? If epithelial cells grow a lot and increase in size a lot and divide often, that can increase our risk for them to do something atypical. And an atypical overgrowing epithelial cell is a carcinoma. So that's why that has that increased risk. So some inflammatory processes of the breast tissue, you could have fat necrosis or lactational mastitis. You could have mastitis otherwise, right? Mastitis is inflammation of that breast tissue. Lactational mastitis is talked about more often because it's occurring during breastfeeding because the breast tissue is under more stress and duress during that time. You really see an increased risk of bacterial infection because of nipple cracks or nipple dryness. And so Staph aureus is your most common pathogen. Cabbage leaves to the breast is like one of my favorite things to reduce swelling and irritation from a mastitis. Obviously, if you have like a true bacterial infection, treat that. But cabbage leaves, like stick 2 cabbage leaves in your bra, works. There you go. That's not on the NPLEX. Just saying. Fat necrosis, benign, painful due to injury of breast tissue. You'll see necrotic fat tissue and giant cells on biopsy. Obviously not great. Okay, tumors. These are the benign tumors of the breast tissue. The one that's the most important is fibroadenoma. It's the most common one seen in females, typically diagnosed under the age of 35. It's small, it's well-defined, it's mobile. It can be painless or painful. It's composed of fibrous tissue and glandular tissue, and it increases or worsens with estrogen. So you can see a cyclical change here during your cycle. Intraductal papilloma, this is a fibro plus epithelial tumor. It occurs within your lactiferous ducts, so in the actual ductal tissue. It can occur beneath the areola. It's the most common cause of nipple discharge. There's a slight increased risk for cancer with this one. And then the phylloides tumor, this is a large mass of connective tissue, typically only seen in patients over the age of 50. But I would say of these, no fibroadenoma. That'd be your best high yield here. Gynecomastia, kind of in the side, breast enlargement in males due to increased estrogen. In prepubertal states, it's physiologic, but after puberty sets in, we would consider it pathologic. Lots of etiologies can cause this. Cirrhosis is one to keep in mind. Obviously, hypogonadism, Kleinfelters syndrome, our XXY chromosome, testicular tumors, lots of different drugs, and more can cause gynecomastia. And then we get into our breast cancers. So some general things to keep in mind with breast cancer. Our risk factors are going to be increased age, a history of hyperplasia, family history of breast cancer, our BRCA1 and 2 mutations, any increased estrogen state or unopposed estrogen state. So that kind of includes your null parity, your obesity postmenopausal because of increased adipose tissue that can increase estrone concentration, absence of breastfeeding because you have breast milk that's dried in those ducts and it can cause long-term inflammation, increased number of menstrual cycles. If you're menstruating for longer, you have more unopposed estrogen, later age of first pregnancy, increased alcohol intake, the list goes on and on, okay? In males, your risks are really Kleinfelters and BRCA2 mutation, but you could, in theory, anything that causes gynecomastia could increase your risk, but really BRCA2 mutations and Kleinfelters are the two in males that I want you to know. Oftentimes, if it's metastasizing, you'll see it in axillary lymph nodes. That's a prognostic factor to see how easy or how challenging it will be to treat and the level of severity. And then depending on the type, we'll look at some different types here, but you'll see an amplification or overexpression of estrogen/progesterone receptors or HER2. Triple negative cancer in general is more aggressive. We'll look at some types. Some non-invasive carcinomas. They're non-invading other tissues. They're sticking to their tissue that they're involved in. So we have our ductal and our lobal carcinoma in situ, and we have Paget's disease. So our ductal carcinoma in situ is going to fill into the ductal lumen, and we'll see microcalcifications. You'll see early malignancy with this, and you will not see basement membrane penetration. So it's going to stay locally to the actual ductal lumen. Versus lobar carcinoma in situ, you're not seeing any mass or calcifications. This is often your incidental finding. This is why we do mammography. It can increase your risk of cancer in either breast. Your Paget's disease is extension of underlying DCIS, so ductal carcinoma in situ, invasive breast cancer up to the lactiferous ducts and into the nipple. The cells involved are intraepithelial adenocarcinoma cells, squamous cells. So these are your three non-invasives. These three would be good to know. Your invasive carcinomas, I would say of these, invasive ductal is good to know because this is the most common type of invasive breast cancer. This is the classic presentation of the firm, fibrous, rock-hard mass that has pokey parts, sharp margins. Invasive lobular is less common. Medullary, also less common. The one piece with medullary is it can mask as a fibroadenoma. Inflammatory, this is where you can see peau d'orange. You can see the skin change on the surface. And this is the one that has the worst prognosis. So if they ask, what's the worst prognosis type of breast cancer, breast cancer that's the worst prognosis, it'd be an inflammatory invasive carcinoma. Okay, that's our breast cancers. Now we talked about some of these male reproductive conditions. So if we've discussed it, I might move past them. If we haven't, I'll probably stop on them. The first one's Peyronie disease. This is abnormal curvature of the penis due to a fibrous plaque within the tunica albuginea. This is different than penile fracture. Penile fracture is rupture of that tunica layer due to forced bending. This is an abnormal curvature. Typically, minor trauma during intercourse is the etiology. It can be fixed over time. Ischemic priapism, this is when you have a painful sustained erection for greater than 4 hours. You do have an increased risk with sickle cell disease because sickle RBCs block venous drainage. So I'd know about this. Penile squamous cell carcinoma, this is the most common type of penile cancer. This is where you have HPV-16 involved or uncircumcised males as a risk. There are some precursor lesions that you can see here. I think those are low yield. I would just know the HPV, uncircumcised, and most common type of penile cancer. Already talked about this. Didn't mention torsion specifically, but we kind of talked about it. Trauma or spontaneous. Testes, torsing. Talked about varicocele. Talked about left versus right being more. Hydrocele, congenital, acquired. We discussed those. Spermatocele. Don't think we talked about spermatocele specifically. Essentially a cyst due to a dilated epididymal duct or reaped testes. And it's also a fluctuant nodule. So all these seals, you're going to see some type of fluctuants. Yeah. As a spermatocele, a cystocele. Yes, you could see it as a cystocele. Specifically spermatocele because it's dealing with more of the epididymal duct and the reaped testes. But yes, you could see that as a cystocele. Epididymitis, we discussed this one as well. Again, I just have the list of the etiologies. That's what I would have associated. Same with orchitis. And you're dealing with just the location, epididymis versus testes. Then our memory is that mumps orchitis increases infertility risk. BPH, we discussed already. Prostatitis, I also have the association with etiology that would be important. And then testicular tumors. I don't think we talked about testicular tumors, so that's where we'll sit. So testicular tumors, we have germ cell tumors. These are 95% of all testicular tumors are germ cell tumors that produce sperm. So when in doubt, it's a germ cell tumor, okay? Seminoma is the malignant, most common testicular tumor. It's painless, there's a good prognosis. Embryonal carcinoma is also malignant. It's more hemorrhagic and it has a worse prognosis. And a teratoma is benign in children or females, but malignant in adult males. Of these, I would know seminoma because this is the most common and it typically has a healthy, good prognosis over time. Risk factors, obviously issues with descent in testes, Kleinfelters. There's others that you could list here. These are the two big ones. Non-germ cell tumors, less common. Think Leydig and Sertoli. So those cells that could be involved are the non-germ cells, the hormone-producing cells, the helper cells. Both of these typically are benign. Prostate cancer tends to be adenocarcinoma. That posterior lobe metastasizes to spine. We discussed that. And I made it through. I did have one aside that I wanted to get to before I open it up to y'all. And it is on Kleinfelters versus Turner syndrome. I've discussed Kleinfelters a lot throughout the time. We remember Kleinfelters as being seen in someone who's biologically male with 47 chromosomes with an X, an X, and a Y. 2 X chromosomes plus a Y chromosome. Contrast that to Turner syndrome. This is someone who's biologically female with 45 chromosomes with an X and an O, an absence of a Y chromosome, an absence of a second X chromosome. So Turner syndrome, you have XO. It's associated with the SHOX gene, SHOX gene, and it's associated with shorter stature, typically in females. Okay. Where you'll see let me see here. Where you'll see in males in Klinefelter syndrome, a bar body due to the inactivated X chromosome. In Turner syndrome, you do not see a bar body because there's only one X chromosome present. You can't have one that's inactivated. But Turner syndrome is the most common cause of primary amenorrhea. That's why I wanted to have that out there. They will often have a question about genotype or phenotypic expression and have Klinefelters, Turners, and then they may throw in a couple others as well involving X and Y chromosomes. Klinefelters and Turners are the most clinically relevant. So be able to differentiate those two and you should be fine for most of those questions. I think those were my big ones. Okay. What questions do you have for me? I saw a question in the chat really fast. Individually and overall. Sure. Most common cancers worldwide, individually and overall. Sure, we can come up with a list. Let's do that. That sounds great. I just went through females only, but those are only female repro cancers. While I'm pulling up my list of cancers, any other questions in the house or online? You're in the house. Either or. Yeah, content or test day. I'm fine with either. Parking is free, is parking hard to find? They have a lot. I believe it's a paid lot. That's at least from what I remember. There's a parking lot at the hotel. I do believe it's a paid lot, but there typically is no issue with parking if you want to park there. If you want to park somewhere else, it's about a mile, 0.25 maybe from NUNM, 0.7. Oh, great. Less than I thought. I made it more. Yeah, so you could probably park here and walk or park here and get a ride over. That would be also fine. I would just give yourself plenty of time in the morning. Yeah, good question. I drove and parked. I took the L and paid the money. But it was nice to leave right after. Walking could be good too, though. Yeah. Plan for your lunch. That would be my big thing. So figure out what you're gonna do for lunch. Are you gonna bring a lunch? Are you gonna go to lunch? Where are you gonna go to lunch? Are you gonna order lunch before? Have it dropped off? Eat something during the break. Okay. Don't study the morning of. Don't do it. Don't do it. Yeah. It won't help. I promise you. You're just gonna freak yourself out. You can study the night before and then go to bed and then don't study anymore. If you feel like you have to do some flashcards during your break, fine. But it's not gonna help you. I promise. Okay. What else? Other questions? Oh, wow. There's 9 questions in the chat. Okay, sorry. My bad. Okay. Cancers, I'm getting there. Is chewing gum allowed in the testing room? Oh, good question. I don't know. I'd have to look on NABNY's website. This is a good just thing. You pay. Thanks, Ryan. Can you wear? Yeah, there's no dress code. You can wear whatever the heck you want. Pretty sure. Okay, that's not what I wanted to do. There's no dress code at all, so you can wear whatever you'd like. Card is, yeah, it's parking kitty. But if you're really concerned about like rules and processes, these are all their rules and processes on NABNY. I did post this on your website. This is on the Moodle page, but this does go through like their new COVID-19 policy, which pretty much means like if you have COVID, please don't come unless if you, yeah, just don't go. But you don't have to wear masks anymore, those type of things. But it goes through all of the testing procedures, day of stuff. So if you're like me and like want to know exactly what's happening, you can read through this. They're pretty chill. Their base is in Oregon for like the whole organization. They're gentle. They're nice. They understand it's high stress. Do remember your ID, your government issued ID, and print your registration ticket, not the morning of. Don't do that. I can't tell you how many times I've gotten like a frantic text. I'm like, I cannot help you print something the day of. I will not be here. So print your reg ticket beforehand. That they will not let you take it if you don't have a government issued ID and your registration ticket with you on the day of. That is a hard rule. You can't bring food inside, but yeah, I would say if you're chewing gum, just chew it until they tell you can't. Okay, so common cancer diagnoses would be breast, top, lung. This is worldwide. Breast, top, lung, second, colon, rectal, third, prostate, fourth, skin, fifth. Top 5 for female and male combined. Okay, that's based off of new cases, so prevalence, not incidence, prevalence. Death would be lung, colon, rectum, liver, stomach, breast. Okay, but no, top cancer, breast worldwide, then lung, then colon. Hope that helped. That answered your question, online person. Okay, yes.
People like nationally sitting.
Gosh, how many grads do you have nationally? 400 maybe or less? I don't know. 200 maybe? 300? Not a lot. Statistically, yeah, they don't purposely fail people, right? They're not trying to they're not saying, okay, we have to fail 50 people or something. It depends on how everyone does. Like if everyone does great and better than 70%, everyone would probably pass. Typically that's not the case. So the cut score is lower than a true pass rate. And so then there is people that are below the cut score. Y'all are gonna be above the cut score. I know it. Know it. You have to go in with confidence. Power pose the shit out of that day. Okay, what else do we have? Anything else important? 237, thanks, Ryan. 237 ND degrees in the US. Wow, you have all the facts. Ryan has all the knowledge. Ask him. He knows it all. Yeah. You know all things, all the secrets, like Gretchen Wieners. Okay, I'm done. All right, thank you guys for attending. I really appreciate you being here so I didn't talk to myself the whole time. Reach out if you have any questions over the weekend. I will be available via phone for emotional support or whatever you need. I am happy to be open to that. I'm happy for that conversation. And then I cannot wait to hear about all of your excellent pass scores once they come in 5 weeks from next week. Thanks. Thank you all. Bye, online team. Good, I'm glad.